So I'm going to talk about treatment-free remission, about what it means, about the experience so far, mostly focusing on the study that we ran in Australia, a little bit about stopping drugs other than imatinib, and then some sort of recommendations as a summary. So treatment-free remission is almost certainly not a cure. So when we talk about cure, we mean that the leukemia is completely gone, that there's absolutely nothing left. We also mean that the person has no symptoms or signs of their disease, that the disease will never transform into a more aggressive phase, that no treatment is required, and that it's permanent. So although we can't say that treatment-free remission is a cure, some of these requirements are met. So some of the people in treatment-free remission have been off treatment without progression for a number of years. Of course, we can't say that it's permanent because we don't have sufficiently long experience at this stage. But the first person to stop imatinib in Adelaide stopped almost 10 years ago and remains in a molecular remission. So the early results are looking very encouraging. So the original treatment-free remission was an allograft. It was the only treatment available until a decade ago that enabled you to be completely free of the disease in the long term. So you can see here that those people who survive their transplant and don't relapse in the first few years are mostly cured. So treatment-free remission, in a way, is not a new idea. It's something that's been around for 20 or 30 years. It's just that allogeneic transplantation was a possibility only for a relatively small number of people who were young enough and had a suitable donor. Almost 15 years ago now, François Mahon, who has been one of the leading French researchers in this field, reported on a small number of patients who were treated with interferon, and showed that people who were PCR negative, so no detectable leukemia after interferon, which was of course extremely rare, because only about 20% of patients treated with interferon achieved a cytogenetic remission. So the number of people who achieved a molecular remission was probably just a handful, maybe 3 to 5% or something. But in this very small group, they were able to show that there were some people who could stop interferon and remain free of treatment for a number of years. And so that was published back in 2001. And I guess that these observations sowed the seed for treatment-free remission with TKIs, which followed. Interferon is a very interesting drug. We still don't really know exactly how it works. It has lots of different effects, including effects on the immune system. So a group of German researchers showed that if you gave interferon after imatinib, that even though you had stopped the TKI, you could get progressively deeper responses, and that these deeper responses were associated with the emergence of an immune response against the leukemia, which is a bit like a transplant where you're using somebody else's immune system to recognize and kill off the leukemia. So there was an idea that maybe interferon produced these long-lasting remissions because it made some change to your immune system, which then enabled your immune system to hold the leukemia down, even though it wasn't completely eradicated. So the first people who stopped imatinib mostly did so because of toxicities or because of intercurrent health problems. And what we saw was a very rapid increase in the level of BCR-ABL quite early after withdrawing the drug. So these are four patients in Australia who've stopped imatinib. And you can see that when the leukemia comes back, it rises very rapidly. You can see it's like a rocket. It's really shooting up very quickly. So each dot here is a month apart. So you can see how someone has gone from a complete molecular remission to close to the level of MMR, which is this line here, in a matter of 2 or 3 months. And this highlights the fact that even when someone's had a good response, the leukemia may be there just underneath the surface, ready to come back as soon as the drug is gone. And so this highlights how important it is to monitor these people very closely, because things can change in the first couple of months after stopping the drug. So the idea was that if anyone is going to be able to achieve a treatment-free remission on imatinib, you would want to pick the best possible group of patients in whom to start. And so we took people who had had no detectable leukemia using a good quality test for at least 2 years, and in some cases it was substantially longer than 2 years. And we were then stopped imatinib, and we did PCR every single month, so that if the leukemia reappeared, we could start the drug again straight away before people relapsed to a worrying level. So the Australian study enrolled 40 patients, and I'm going to go through the results in the next few slides. So we said that the trigger to restart treatment, so the relapse definition, would be loss of MMR, or it would be any 2 positive results at any level. So if somebody had 0.001 and then next month 0.001 again, we would consider that to be a relapse and we would restart. So we were very strict in how we defined relapse, and we treated people quite quickly if things reappeared. So you can see from this slide that it was a fairly typical CML population, roughly half male and half female. The average duration of treatment prior to coming onto the study was 6 years. So these are not people early in their treatment. They've had a long, deep response. And the average period of undetectable leukemia was 3 years. So although the minimum was 2, the average was 3, and the maximum was 7 years. And this is what we found. So around 43% of patients remained in a molecular remission without the need for treatment. And although this was updated when we had up to about 6 years, it's now about 2 or 3 years further out from that. But you can see that the people who relapsed almost all do so in the first 6 months. A smaller proportion experience a later relapse, and so the latest relapse was just past 2 years. And then no one has relapsed beyond about 2 years. So the people who've made it out here are all still in remission. But I should emphasize that these people were being monitored every month for the first year, and even out here we're still monitoring them every 3 to 6 months. So we're not sufficiently relaxed to just kind of walk away and forget about these people. We want to make sure that they're still safe 10 or 15 years down the track. When we restart imatinib, does it still work? Do they have as good a response the second time around as they did the first time? So what you can see here is that, so this black is not in MMR, the grey is not in CMR, and the white is no detectable leukemia. So you can see that very rapidly people get down to low levels of leukemia, and at later time points almost everyone is back into a molecular remission. So we were very reassured by this, that short time off treatment for people who relapse, as long as you rescue them quickly by restarting treatment, there doesn't seem to be any loss of response at later times. So there have been other studies from around the world. So this is the second French study. So the first French study was STIM, which showed identical results to the Australian study. This is the A-STIM study, in which they changed the relapse definition. So if you had a couple of low positives, they ignored that and they waited until people lost MMR. So they were still watching people very carefully, but they let things go a little bit longer before they acted. And what they showed was that if you use this more relaxed definition, that only about 40% of people needed to restart treatment. So about 60% of people were able to remain in MMR without therapy, as opposed to the 40% in CMR without therapy. So I guess what this starts to complicate things, because treatment-free remission means different things in different studies, and you have to understand these differences. So what about stopping dasatinib or nilotinib? So again, the French have published this relatively small numbers of 52 patients who'd been followed at least 12 months after stopping dasatinib or nilotinib. 2/3 of these people were on their second-generation drug because they were intolerant of imatinib, so they switched because of side effects. 10% got that drug as their first-line therapy, and about a quarter switched because of imatinib failure or suboptimal response. So overall, they saw very similar results to the A-STIM study, which I just showed you, with about 60% of people still in MMR at 12 months. But if you look at the people who switch because of intolerance, as opposed to those who switch because of resistance, the results are very different. So the people who were intolerant had a 67% TFR rate, but only 40% for those who had previously had a suboptimal response to imatinib or failure. So I guess this means that in those people who've had a previous TKI-resistant leukemia, that these are a higher risk group in whom we need to be more cautious. They haven't reported separate results for nilotinib and dasatinib, but they said that there was no major difference between the two drugs. Now, the only study that I'm aware of that reports on the outcome of a single drug is the DADI trial from Japan, which is about to be published in Lancet Hematology. So this shows very similar results to the second generation TKI study. So they define treatment-free remission as MR4, so a level of less than or equal to 0.01% BCR-ABL. And what they showed was that, again, people who were on second-line dasatinib because of intolerance, about 60% of them remained in treatment-free remission, whereas those who switched because they were resistant to imatinib, less than 10% remained in treatment-free remission. So your treatment history, where you've been before, has a big outcome on what happens down the track, and it's important never to forget about that. Another very interesting observation in this study was they looked at natural killer cell numbers. So natural killer cells are a particular type of immune cell, and they found that people who have higher numbers of natural killer cells were less likely to relapse. And so again, that's a little bit like the interferon story, that there seems to be something about your immune system that might be one of the factors that determines who stays in remission and who doesn't. But this is an area that we really don't understand very well. So in Australia, we've done a treatment-free remission survey, which hasn't been published yet because I've been doing other things and I need to work harder. So we contacted a whole load of people who were on TKIs, who'd had a good response to TKI, so they were at least in MMR. And we asked them, if your doctor thought that it was reasonable, that it might be safe for you to stop your TKI at some time in the future, would you be interested? And if you would, why? And if you wouldn't, why not? So this was done as a telephone survey around Australia. So we got 87 responses. Again, a fairly typical CML population for Australia, around half male and female, an average age of about 56. And as you'd expect for people who've had a good molecular response, they'd been on their treatment for quite a long time, so an average of 6 years of TKI treatment. So I think this is important because it resembles the stopping studies. They are the kind of people who would have been able to stop. Interestingly, almost 80% of them had talked to their doctor at some time about what a treatment-free remission means and whether it might be possible for them. And 80% of them said that if their doctor thought that it was reasonable, they would be prepared to stop their TKI on their doctor's advice. We saw no difference according to age, so we didn't see that younger patients were more keen to try. It didn't matter how old people were, didn't differ between men and women, didn't matter how long they'd been on treatment or which treatment they were on. And interestingly, it didn't matter how bad their TKI side effects were, because when we did this survey, we thought, oh, well, the people who are really struggling with stomach upset and other side effects from imatinib, they'll be the ones who really want to stop. But in fact, it turned out that that wasn't the case at all. It made no difference to whether or not people wanted to stop. So in the survey, there was a single question where people got to say what they thought, rather than just saying yes, no, 1, 2, 3, 4, whatever. So they actually got to talk and tell us what they thought. And so when these responses were analyzed, it turned out that even though the people with more severe side effects were not the ones who desperately wanted to stop, everybody said that they were concerned about side effects. So even those who had mild side effects wanted to stop. And the other thing that came out was that people wanted to stop because they were afraid of side effects that they don't have now, but they might get in the future. So the possibility of future side effects. In some people, this was because of pregnancy, because if a woman wants to be pregnant, it's not safe to be pregnant on a TKI. So there were lots of different things that went into this decision. A lot of people complained about the inconvenience of having to remember to take tablets every day or to have to time their tablets around their meals. And very interestingly, some people wanted to stop their drugs because they thought that it would help other people. So some people said that they wanted to stop their drugs because they were so expensive and they wanted to save the community money, because of course in Australia, we as taxpayers pay for the drug, an individual patient doesn't pay. So they felt that it would save the country money if they weren't on a TKI. And some people wanted to improve the science. Some people wanted to advance the situation to improve the knowledge of CML. And most people, predictably, who didn't want to stop were worried that it would be unsafe. So they were afraid that their leukemia would be resistant when it came back. Some people pointed out that they couldn't have their tests done often enough for it to be safe. And some people were aware that people who stop imatinib have a withdrawal syndrome, that some people who've been on imatinib for a long time and stop it get lots of aches and pains, which interestingly is a bit similar to the side effects that some people have at the beginning. And some people just said that they wanted more information, that they needed reassurance from their doctor, or that they needed to understand better what TFR means. So this is the last slide, because I know I've gone over time again, and I do apologize. So if you have previously had resistant disease, you should think very carefully about whether or not it's the right thing for you to stop, because in most cases, you will have to restart your TKI. It probably doesn't matter which drug you've been on, as long as you've had a good enough response, and that has to be at least MR4 and possibly better than that. You have to have sustained this remission for at least a year, but probably longer is better. You must do this only in cooperation with your doctor. This is not something that you can safely do on your own. You can't sort of wander off and forget about things. That would be very dangerous. And if you can't get PCR done every month, at least for the first 6 months, and still regularly thereafter, then it's not safe for you to stop. So I was talking to Raymond over lunch. If in Hong Kong they can only do a BCR-ABL PCR twice a year, then nobody can stop in Hong Kong, because if you can't do the test more often than that, it is just not safe. So thank you very much.